Good morning, good afternoon, good evening, everybody. We are just giving everybody a few minutes to join, but in the meantime, I wanted to let you know that we are offering interpretation, a simultaneous interpretation for this meeting. So you have two options, either English or French. And so if you click the little world icon at the bottom of your screen, you should be able to choose which language you would like to listen in on. Okay, I think we can get started. Welcome everybody to the Global Digital Health Network September monthly meeting. My name is Christina Valella, and I am one of the co-chairs of the Global Digital Health Network. And I'm really excited for our session today, which I'll introduce in a moment. A few housekeeping items before we get started. We are offering interpretation for this meeting, so please do click the world icon, interpretation icon at the bottom of your screen, and you can select whether or not you would like to listen in English or French. And then additionally, we have a few announcements about from the network. Our annual meeting, the Global Digital Health Forum, one of the premier digital health conferences in the year, is going to be held December 6th through the 8th. It will be a virtual event again this year. We had our first virtual event last year, and it was a really resounding success with over 2,000 people turning in from over 110 countries around the world. So we're excited to continue that momentum of really expanding our audience, and we will be having a virtual event again this year. Our call for abstracts opened about a month ago, and it will be closing on Monday, September 20th. And please stay tuned for registration, which will be opening soon. And you can get more information from the bit.ly there, and perhaps somebody from my team can drop that bit.ly into the chat as well, in case you would like more information either on the forum itself or on the call for abstracts. So today's meeting is on digitizing clinical guidelines, sharing learning from the development of clinical decision support algorithms, on the development of clinical decision support and management of childhood illness in low and middle income countries. And this is our agenda for today. I will be turning it over to my colleague Karel Pele at Find to be our moderator for today's session. But you can see we do have a pretty packed agenda. This meeting is scheduled to be an hour and a half, and we have a number of really exciting presentations, as well as a roundtable and time for Q&A. And so we have a number of different panelists here today, and I'm really excited for you all to get to meet them and hear their journey and what the work they've been doing as this collective community of practice. So you see, we'll have a presentation on the processes learned kind of from their community of practice on developing these clinical guidelines. We'll hear from the WHO on their SMART guidelines and MCARE project, and then a roundtable of a number of organizations doing this work within the community of practice. Then there'll be time for question and answer, and then I will close out the meeting. So without further ado, I'd like to introduce Karel Pele from Find, who is going to be our fearless moderator for today. Corel, over to you. And I'm going to stop sharing so you can share.
Thank you so much, Christina. Good morning, everybody, and good afternoon. Thank you to the GDHN team for organizing this event today and for providing this platform to showcase the EIMCI working group's work to the global health community. It's really an honor to be here today. So my name is Corel Pele, and I'm a senior scientific e-health officer in the pneumonia and fever program at FIND, the Global Alliance for Diagnostics. I've been involved in the EIMCI working group for the last 3 years, and I'm very excited to moderate this event today, whose aim is to share the learnings from the EIMCI working group on the development of clinical decision support systems for the management of childhood illness in low and middle income countries. So before diving into the findings, I'd like to share a bit of background information. So as you know, children under the age of 5 are still dying at alarming rates. 5.4 million under 5 deaths are estimated every year globally, with the majority in low and middle income countries, and in particular in sub-Saharan Africa. This is partially due to limited human capacity, minimal to non-existent diagnostic tools, and simple point-of-care tests to laboratory services, leading to inappropriately diagnosed and treated children. In response to this global health crisis, UNICEF and WHO developed a guideline to support high-quality diagnosis and management of childhood illnesses in resource-constrained primary healthcare settings. This guideline is called the Integrated Management of Childhood Illness, or IMCI. It is a simple, structured approach to support health workers implement evidence-based care. It supports the identification and classification of illness based on signs such as cough, fever, or diarrhea, to provide treatment or referral to second care for more appropriate management. Yet adherence remains really low in many settings, leading to misdiagnosis and inappropriate treatment decisions, in particular antibiotic overuse. As a means to address this limitation of IMCI, adherence issues, and to overall improve evidence-based care, several global health actors have developed and implemented IMCI-based clinical decision support systems in the last decade. They have demonstrated significant improvement of quality of care and health outcomes for children. So what are clinical decision support systems, or CDSS? They are digitized job aids that combine an individual's health information with the health worker's knowledge and clinical protocols to assist health workers in making diagnosis and treatment decisions. They combine patient clinical information, history, diagnostic information to provide patient management recommendations for preventative, curative, or supportive care. However, translation of narrative guidelines into decision logic often requires interpretation due to the requirements to adapt to local context. This has led to the development of different CDSS, although founded from the same source, IMCI. Because these tools are used for patient care, this calls for transparency in CDSS content and development processes. So this has led to the formation of the EIMCI working group. This working group was convened by and facilitated by the Global Health Forum, GHF, and Geneva Science Policy Interface, GSPI, and has worked together for the last 3 years. The working group includes a diverse set of stakeholders with unique experiences in EIMCI, from humanitarian organizations such as MSF and ICRC, academic and research institutions such as Swiss TPH, Unisante, and Ifakara Health Institute, and NGOs such as Terre des Hommes and FIND. WHO later joined the working group to share their learnings on smart guidelines development for antenatal care. These provide guidance for the translation and adaptation of narrative guidelines into digital system at country level. Specifically, the aims of the working group were to share the context in which EIMCI's CDSS were built and the objective behind each CDSS program, to share the content deviations from EIMCI clinical guidelines and methods and processes of development. This work was accomplished in a series of roundtable discussions, input through semi-structured questionnaires and draft documents, and feedback through draft documents, sorry. So this leads me to introduce the next speaker, who is Clotilde Rambaud. Dr. Rambaud is a medical doctor and epidemiologist and serves as a digital health advisor at MSF. She has extensive experience developing and adapting clinical content for EIMCI-based CDSS and conducting implementation research on complex health systems, strengthening interventions. Clotilde will provide a synthesis of the findings from the EIMCI group. Clotilde, the floor is yours.
Sorry, trying to share my screen. Okay, is it okay? Can you see my slides?
Yes, it's good.
Yeah, so thank you very much, Karel. So indeed, I'll try to drive you through all the result and the findings in this comparative assessment that we conducted. So first, let me introduce you the 4 tools that were compared here. So the first is IEDA, developed by Terre des Hommes. Then we have the MSF eCare, developed by Médecins Sans Frontières. LMIC, developed by the Swiss TPH, and EPOCT Plus, developed by Unisanté and Swiss TPH. So if, as mentioned earlier, all these tools share the same objective as the EIMCI, that is to improve the management of childhood illness at primary healthcare level in low and middle income countries, they've all been designed by different organizations that have different contexts of intervention, and so with slightly different goals. IEDA was developed by Terre des Hommes with countries' health authorities to improve the quality of healthcare, build local capacity, and support national health information systems. So built from the inception to reach national scale, it is now the tool that in use since 2010 in the field. It is the tool that has the largest deployment at scale to date. MSF eCare was developed by MSF, which is an emergency humanitarian NGO, and it has the aim to improve the quality of care for our patients and to harmonize the clinical practice among health staff that come from many different countries and so from many different health systems with different practice. So it's been deployed in complex humanitarian settings since 2017. LMIC was designed initially in a research project, and then it has been deployed in humanitarian settings with the International Committee of the Red Cross, the ICRC, but in close collaboration with the country's health authorities, looking also for sustainable implementation at scale. Whereas the last tool, EPOCT, was developed by a research group to further explore how the use of new technology, new diagnostic tests, new format of CDSS, and machine learning to further improve childhood illness management and child health. So all these tools have been developed at different time and have reached different size or scale of implementation, but most of them have developed their intervention and implementation with very large partnerships. So in this work, we aim at comparing 2 main elements. So first was the algorithm content, and to look at how their scope, content, and structure had or not deviated from the initial IMCI, and to look at whether we would find similarities in the modification that were implemented when there were some. And then to look also at the process that the organization had followed to develop this clinical content, especially looking at what source of guidelines were used, what and how it was documented, the process and the final content, and what kind of process were set up to ensure that there are regular updates and improvements in the CDSS we proposed. So first, looking back at what was the scope and content of the IMCI, so Integrated Management of Childhood Illness Algorithms. The IMCI was a strategy launched in the late 90s by WHO and UNICEF to tackle the high childhood mortality in low and middle income countries. So it proposes some clinical protocols and pathways that target the main causes of under 5 morbidity and mortality. It is built as simple clinical pathways for 4 main symptoms, and so it addresses only few possible classification or diagnoses that were identified as the main killer. Where it has been implemented, we observed that there were challenges for the health worker to adhere to the recommendation in the guidelines, and also especially to manage symptoms or diagnoses that were not covered in the protocol. And a worse quality of care was observed for the problem that were not covered by IMCI. This was particularly striking for the fever assessment. In the 90s, the first version of the IMCI was really focusing on the detection and treatment of malaria cases when it comes to assessing fever. But since 2014 and the introduction of the malaria rapid diagnostic test, the health worker were left a bit alone to decide or to find a way to identify the cause of the fever, establish a diagnosis, and then propose an appropriate treatment. These are a few of the limitations that triggered some modification in the scope and contents of the tools. Now, if we looked at the 4 CDSS that we observed here, we quickly identified that the modification that were implemented had been highly dependent on the context, the kind of health facilities, the level of the health worker, and the material that the organization could provide. But most of the CDSS had extended the scope, adding a wider range of syndrome presenting symptoms, and one tool had also extended the age range to propose management recommendation for older children. All of the organization mentioned that the aim of this extension of scope was actually to enhance care for the non-IMCI presentation, but also to improve or promote the adoption of the tool by the health worker, that were more likely to use a tool that would provide them support for a broader range of the condition that they face in their consultation. Another reason or rationale for expanding the scope and the content was that it was perceived easier to propose complex protocol to health worker when we were presenting it with the support of a mobile application that would help them navigate through complex protocol, as compared to providing paper algorithm that might be very difficult to navigate through. Most of the organization of this 4 CDSS also incorporated additional content, even for the syndrome covered by IMCI, including, for example, additional diagnostic tests or clinical criteria, with the aim to improve the specificity of the diagnosis and therefore better target treatment. And this was particularly true when the objective of this CDSS was not only to improve the quality of care, but also to promote a better rational prescription of antibiotics. Then we looked also at the structure, just to highlight the initial structure of the pathway or the workflow in the IMCI that is presented in the chart booklet is very linear and sequential. You have 1 page for each syndrome that are all built a bit on the same way, with the first part that is driving the assessment with a question to be asked, and then element to look, listen, and felt, looking for main symptoms. And then there is a classification based on this assessment, and according to the classification reach, it proposes a treatment to be prescribed. If meant to be used literally in a consultation room, it would mean for the health worker that he has to flip back and forth between the different pages and between history, examination, and classification if the child presents more than 1 syndrome. So now when we look at the CDSS and how did we implement the structure, we have to remind that one of the aim of this CDSS is to ensure that the consultation process is improved so that the health worker will not miss any key task. And so it's aimed at enforcing the predefined navigation that we want the health worker to follow, and also to decrease misinterpretation of the clinical recommendation. So actually all of the CDSS that we're talking about today have modified the structure. And the main reason to modify the structure was first to expedite the identification and management of the children with very severe disease, ensuring that we avoid unnecessary complete assessment if we have to deliver quickly a peripheral treatment and refer the child to a higher level health facility. And the other reason was also to better integrate the different assessment components. But also all have modified the structure. We realized that the approach and the extent of the structural modification had varied a lot between the tools. Some staying much more closer to the IMCI structure and some going much further into trying to follow a regular consultation flow that will group all questions together, then group all clinical examination for sending possibly a child to the laboratory and before then reaching diagnosis. Clearly, a consensus on the reason why the organization had modified the structure was that it was very important to ensure that the use of the application would minimize the disruption and would not unnecessarily delay the consultation. Now, if we look at the process for the the development of this clinical algorithm content, we identify key steps that we all had implemented in different ways sometimes, from the identification of needs and objectives that comes also with the selecting the source of guidelines recommendation. Then after we define exactly what we want to do, we needed to develop a human readable algorithm that needed to be validated by a group of experts before getting into digitalization, and that all this would be further refined and redesigned with the user in pilot implementation before it goes to full-scale implementation. Clearly, for all of the organization, we acknowledge that developing a CDSS is a long and complex process, and that the iterative cycle of refinement are key and should be planned from very early in the process. If we look at the source of content, all of the tools that have been assessed here have had to use additional source of guidelines or evidence aside from the IMCI guidelines. The main reason was that actually we work with primary healthcare health worker that are expected actually to use different kind of guidelines often in a country, and that all of these guidelines may have conflicting recommendation because they're not always in line with the latest evidence. There are long update cycles, and sometimes some guidelines may be more up to date than others, and that it might be difficult for a health worker to select which information to take. And the decision logic that is proposed in guidelines is not always clear. There is sometimes a huge need to remove ambiguity and need of our interpretation of the recommendation that triggers sometimes the need to look at alternative source of evidence synthesis, and that we also needed to look at epidemiological data in some context to make sure that we can adapt this guideline to the particular context where it will be implemented. So what was clear for all the group, when in the discussion is that these decisions on the scope of the tool and the sources to be used to generate the new recommendation in the algorithm should be made with expert stakeholders and adapted to the targeted context. An important element that was identified and mentioned by all of the group members was that a very important step in all this process is to have transparency of the content of our algorithm, and that in order to have this possibility to review and validate the final content with our key stakeholders, we needed to have a human readable version of this algorithm. And if all of the organizations have developed some human readable format, we could see that the format varied a lot between the different tools. Then updates over time was something that was also highlighted as a key component. We are building complex algorithms, and in the process of digitalization, we need to expect that there will be difficulty in ensuring that the final electronic tool actually implement only but all the recommendations that were expected to be in the algorithms. and that may be a lot of differences between the guidelines that are more generic and then the reality of the field where we implement it. So all agreed that it's important to start small and plan for update cycles, and that it's key to maintain throughout a human readable algorithm so that we make sure that we can communicate on the key decision on what recommendation should be implemented. Sorry. So in summary, this working group, I mean, here are the point that we find very important in this exercise. Clearly, for the organization participating, we saw that IMCI-related CDSS can assist health workers in providing better evidence-based care. It was clear to us that interpretation and adaptation are required when we try to translate narrative guideline to CDSS. That this kind of collaboration between algorithm developers brings a really great opportunity to share learning and to reflect on our processes and then to improve it. We identify some common themes in the algorithm development across the 4 CDSS. First, that the modification to scope, content, and structure were needed and were highly driven by the context. And that iterative development process with a strong involvement of stakeholders in defining, documenting, and updating algorithm over time are super important. And also we had common themes in the way we developed and adapted the IMCI to build our CDSS. We saw high heterogeneity in the processes for algorithm development and documentation in all our organization that are clearly due to the lack of standard practice or process, and the fact that we were also learning by doing. And that's why we were very happy to, at this stage, share a bit what we had done. But we were also very happy in the course of this working exercise to welcome in our group some representative of WHO Smart Guidelines group, because they were actually proposing new common languages and standard core tools that could really serve as a reference for further algorithm development. For us, we realized that it's a great opportunity to improve the standardization in the development, and will help us to enhance the transparency, and the quality of the final product that we develop. Even so, we realize that we probably will not tomorrow have a single tool. We are really eager to improve our processes and make sure that we can also bring more transparency on what we have done so that it can serve to others. So I think after the references, that's where I stop.
Thank you very much, Clotilde, for this great overview of the EIMCI CDSS developed by these 4 organizations and for sharing their lessons learned. As mentioned earlier and mentioned by Clotilde, in the earlier days of the working group, WHO released a SMART guideline for antenatal care. And since then, WHO developed and released SMART guideline for IMCI for use in emergency settings and a tool called EMCare. WHO joined the working group to share their experience formulating guidance for guideline developers, technologists, and countries to navigate this complex process of translating WHO narrative guidelines and recommendations into digital systems. As countries are more and more investing into solutions to digitalize systems, SMART guidelines provide a common language and references to facilitate this transformation and ensuring content fidelity and systems integration. With that said, I would like to introduce our next speaker, Dr. Nigel Rollins. Dr. Rollins is a medical doctor in the Department of Maternal, Newborn, Child, and Adolescent Health and Aging at WHO, and a member of the Research and Guideline Development Group. He has extensive experience in implementation research, interventions to improve child survival, growth, and development. Prior to WHO, Dr. Rollins was a professor and head of the Center for Maternal and Child Health at the University of KwaZulu-Natal in Durban, South Africa, where he worked for 14 years. Dr. Rollins will share learnings of the development of EMCare, WHO SMART guidelines for EIMCI use in emergency settings. Nigel, the floor is yours. Nigel, can you hear us? I think we may have lost Nigel. Maybe we should just give him 1 second just to check what's going on with his internet. Oh, there he is.
Carol, sorry about that. I think I'm hoping I'm back there.
No, you are. You are. We can hear you.
Great. So anyway, the one thing I got cut off halfway through your introduction, which was very kind and generous. The one thing that you completely failed to mention is that I am not digitally skilled at all. So I've been on a very, very steep learning curve, and I'm hugely grateful to several of the people on this call. So yes, I'm delighted to share a little bit, but don't ask me too many questions. So WHO has embarked on and committed to converting all narrative guidelines into smart guidelines. And the reasons were very much as Clotilde had mentioned earlier, that in many circumstances, health workers and communities do not immediately and fully benefit from clinical guidelines, whether they're WHO or others, and they don't rapidly benefit from new evidence and interventions. So you can't see the slides, sorry.
I was
sorry,
actually
just,
going to...
yeah. So hopefully, maybe you could just confirm that that's showing again, is it?
Yes, we can see your back, yeah, your slide. WHO Smart Guidelines and EM
Great. So anyway, as Clotilde had been highlighting that health, people often don't get there, and IMCI has variable uptake. The only comment I would make there is that there are many reasons, including political and health systems commitment to things around the quality of care. So certainly the digitalization of guidelines will be an important contribution, but there are many health systems constraints as well that need to be considered in parallel. But certainly it's very true that just looking at this one top line, that from the time of guideline development through to adaptation to guideline usage can take years. And I was involved with much work on HIV, and we saw the long times that it took to translate knowledge into practice. What is even sort of more clear is that WHO guidance for emergencies is even more challenged. Most of WHO child health guidance was never developed for emergencies. It wasn't adapted, nor was it substantially field tested. And so we've been very much reliant on the experience of people on this call and organizations represented in this call to say what was appropriate or what is appropriate. In terms of M-Care, the general vision is to improve health outcomes in emergencies, and emergencies now constitute about 20% of child mortality. So it really is a massive, of those numbers that were shared earlier as the rationale for IMCI in the first place, there's a huge concentration of mortality in amongst displaced populations, because of even more limitation on access to care. So the vision of M-Care is to improve health outcomes in emergencies by making WHO's clinical guidelines available whenever, wherever, and by whomever. And it's a good vision to have, so it is. And the whole process of smart guidelines is now going to be central.
Nigel, we lost your audio. Nigel, can you hear us? Nigel? Nigel, are you back? No. All right. I think we're having technical difficulties with Nigel. So in the schedule has us doing a round table discussion with the panelists and previous speakers. So I don't know. I suggest we may go into the panel discussion, and during that time, oh, here's Nigel's back. Hi, Nigel.
There, sorry about that. I live actually, I'm sure probably have better connections elsewhere, but I think this community very much understands SMART guidelines. I think the main point of this slide is that WHO is committed to this translation of all future guidelines. And I think that's an important commitment. And WHO is definitely on a learning curve toward that. MCARE as a project is the pathfinder for the organization in some respects, and certainly for the care in emergencies. We are seeing newborn and child health as the pathfinder for a much larger population. Even within newborn and child health, we're really focusing on the IMCI, acute malnutrition and newborn care, as the initial focus for what we're referring to as a prototype, where we're simply wanting to develop a prototype all the way through to layer 4, and to have that, as something that we can field test early next year. You'll be very familiar with this in terms of moving from the narrative to through the DAC, and working then on machine readable components. We are actually doing much of this in parallel, that we have now contracted, building on a Google platform. We have software developers already developing the layer 4. We are completed to an initial layer 1 adaptation of standard guidelines, and that we are deep into the DAC process of digitalizing, and hugely grateful to several people on this call who are actually helping. And as we are moving through this, we are feeding into the layer 3 work, and that's happening exactly at the moment. The question is often raised, what happens that countries are not always in a position to take this type of work on. And I think the nature of the digitalization process is that these can happen in a complementary way, that as we're learning and developing the DACs all the way through to the layer 4 and layer 5, we are at the same time working with the member states and the countries and the health systems to try to build the capacity towards really implementing and using these tools. Beyond 2020, we certainly want to expand the scope beyond IMCI and newborn care. And that is one of the reasons why we haven't sort of maybe approached some of the ones that have been highlighted today, the IDEA and the EIMIC, saying, well, why don't just adapt? And the reason for it is that we want to have a platform that is going to serve all populations. And so the decision was taken that the initial investment to build a platform that will be able to accommodate not just IMCI, but things around non-communicable diseases, asthma and diabetes, DACs, child development, adolescent health for children should all be options for us. Similarly, that we should be able to use the same platform for care of the elderly in emergencies, as well as outbreaks, whether it be things like Ebola, yellow fever, or whatever, that we should be able to, within the same platform, provide the decision pathways. We certainly see the value of being able to distribute layer 3 content to partners, in that many people on this call and many countries who are even represented on this call they already have layer 4 solutions. And so one thing that we can contribute to this effort is L3 content that is consistent, fully consistent with WHO guidance, which can then be adapted by others. So we are certainly looking for continuous improvement and support to the platform, and we look forward to the day whenever we can really apply some machine learning to really optimize some of the decision logic. As I said, we have been working very closely with many of the groups on the call today, and we very much value the input of organizations, the clinical reference group that helped us think through the adaptations for IMCI, and people who've been directly building IMCI models before. And just to particularly acknowledge Swiss Tropical and Public Health Institute, where several of the colleagues from there are really working very closely with us. So thank you very much indeed, Carol, and apologies again for the break in communication. Over.
Thank you very much, Nigel, and thank you for this great presentation on EM care and the processes to use the different layers of the toolkits by countries and technologists. So we've heard from Clotilde Rambaud in the beginning of the session on the different tools and the similarities and differences and the findings from the working group. She shared also the learnings and how these tools were developed and implemented in a context where standards were really lacking. We heard then from Nigel on the work happening at the WHO on the SMART guidelines, providing this missing thread in the community, important documentation and standards to guide the digitalization from narrative to digital tools. I'd like now to move into the panel discussion where we can deep dive into some of the topics and learn more from the respective groups whose tools were presented earlier today. I want to invite back Clotilde Rambaud from MSF, Nigel Rollins from WHO. I'd like to invite Ricardo Lamperiello from Terre des Hommes. Ricardo is the head of health program, and he will share the experience from their program implementation in West Africa called YEDA. I'd like to also invite Thorsten Schmidt. He's a senior clinical consultant at Swiss TPH, and he will be sharing their experience from their implementation called EIMIC. And Rainer Tan, who's a physician and clinical research fellow at the Swiss TPH and Unisanté, and he will share their experience with the tool called EPOC Plus. So welcome everyone, and thank you for joining us today. I want to start first with the topic of algorithm content. In all the CDSS that were presented today, we saw that there were many tools that deviated from the IMCI guideline. Clotilde and Rainer, I wonder if you can help us understand how the scope and the content was modified in the tools and why was this done? Maybe Clotilde, can you give us a bit more insight into this, please?
Yes, thank you, Karel. Yes, so as mentioned, and we have modified the content and the scope to also adapt it to the context of use. And so for us in MSF and for MSF eCare, our aim was to to design a tool that would improve the quality of care. And this is also effort in MSF have been done since years to try to provide guidelines that could be applicable very quickly in the context where we send teams in emergencies. And we have a long experience of having standardized guidelines so that we standardize the practice, because our staff, we work with stuff that comes from all over the world, so we need to standardize that. And we have also some standard of care that comes also with the kind of drug, the kind of support we can bring. And we had somehow to work with our group of pediatricians that had expectation in terms of standard of care. So it made us look at the IMCI, but also look at what was missing for us in order to better support the health worker manage a sick child. And so I see two main reasons for our modification in scope and content. So the first one was like, we wanted to improve the quality of care, but we had also a focus on looking at how we could improve the rational drugs of antibiotics. We had implemented the malaria rapid diagnostic test that was a real game changer in the capacity to decrease the unnecessary anti-malarial prescription, but we were seeing that even with all our effort in training or providing some guidance, we were still seeing a lot of unnecessary antibiotic prescribed. And so when we looked at the IMCI, we identified some limitations, or it was not helping actually to have a proper diagnosis process so that we identify patient need and can safely identify the patient that you leave without antibiotic going back home. So it's true that looking at that, we had to extend the scope. We had to add some condition. We wanted to make sure that the clinician were able to rule out bacterial diseases that were not included in the IMCI. So it made us change and extend a bit the content and the scope. And additionally, I think the first time we blocked our first iteration of this e-care tool, we had a feasibility study in DRC, in a very remote rural area, and the health worker that were very happy to receive more support and get also to understand how it was built with the new evidence that has been incorporated, quickly asked also us to cover even more conditions because they were having a hard time to make the appropriate assessment and decision with regard to eye problems, to mouth problems, and especially to skin conditions. So that also drive us to actually try to extend the scope. So on one side, we were trying to focus on making sure we detect the serious infection that require an appropriate treatment. And on the other side, we also extended the scope to make sure that the clinician would wish to open the tools because it would help them in the condition that they were having a hard time to take the right decision. And I think that's actually the two main reasons, and to improve the uptake and adoption of the tools, but also to be able to cover what we call the non-malaria fever and give more support in providing enriching right diagnosis and right decision for treatment.
Thank you, Clotilde. And Rainer, if I ask the same question from your experience with EPOC Plus.
Yeah, so EPOC Plus is, first of all, it's a research tool that we're evaluating in clinical trials before it's truly implemented in routine care. There are two ways EPOC Plus expanded scope from IMCI, that is age and conditions. So first part for age, we expanded to 5 to 15 years. And so while children below 5 years have the greatest burdens in terms of mortality, those above 5 years are often neglected in international and national policies. As such, mortality of children aged 5 to 14 years in low and middle income countries have been found to be higher than expected and decreasing more slowly over the past 2 decades. As for the expanding of scope in terms of conditions and diagnosis, as said by Clotilde and seen by many tools, healthcare workers are often requesting for more content to be used for the digital tools. And so we can just imagine a healthcare worker who is using a digital tool for some patients and then paper guidelines for other patients. So by consolidating within the digital tool, we hope that this can increase uptake. Finally, by providing more guidance to more conditions, this also provides more opportunity for antibiotic stewardship for those conditions. And then also, as mentioned by Clotilde earlier, there are a lot of national guidelines that often include much of this expanded content. So clinicians are expected to manage these patients. And so by having them included within these digital tools, it can hopefully help them manage them more correctly. In terms of how we expanded content, how we selected additional conditions, we looked at 3 major criteria. 1, incidence of conditions. 2, morbidity, mortality, and potential for outbreak. And 3, the capacity to diagnose and treat at the primary care level where we're implementing these tools. And so as an example, some classifications or conditions not addressed by MCI include abdominal pain found in 5 to 23% of outpatient cases, throat pain in 13% of febrile outpatients, headache in 34 to 81% of outpatients, trauma 4 to 22%. So these are all conditions that a clinician using IMCI would not have guidance. And so by integrating within a digital tool, we hope it would improve uptake. Now, in terms of content, within Epoch Plus, we try to interpret a number of additional narrative guidelines to transform into algorithms. And what we found very fast was that there is a lack of evidence-based algorithms, and algorithms that are developed or models that are developed in one setting often perform worse in other settings. So such, we had to kind of integrate diagnostic and prognostic performance of clinical features when evaluating to integrate within our algorithms for new content. And so often within Epoch Plus, we try to see if we can integrate point of care tools, CRP, pulse oximetry to help with these algorithms. And
thank you. Thank you, Rainer. So I still want to push the questions around the use of the CDS tools in health facilities. So Clotilde, in terms of flow of the questions and the overall use of the tool during the consultation process, can you share a bit more how your tool was developed and how it was adapted to work in the context in which you work in, so humanitarian settings?
Yes, yes, I think what was quite striking earlier is like if I look at, I've been working in this field since quite a few years now, and in the first years, 10 years ago, I would say, the first time we wanted to develop some electronic format for the IMCI, what was quite striking at the beginning is like, you know, the initial team working on that were telling us, okay, we have something that is already well designed and structured as a clinical workflows, pathways, and so just give it to a digital team, and they will provide you something that will exactly implement the IMCI. And just to mention that the first iteration of things were then really sticking to the format of the paper algorithm, but that was not absolutely not actionable in a normal consultation process. And there were things that were not relevant. Like if you follow the IMCI, you can have like the first question is like, you're looking for danger sign. Is the child convulsing? And then you get a yes, the child is convulsing. But if you look at the pathway, the next question will be, is the child coughing? And that poses a problem, because for us, if the child is convulsing, yes, the next step should not be continue the assessment, but should be stop and deal, you know, manage this condition or this severe case. So at least it was really like early in the process, we realized that no, we cannot take this, even if it's not a narrative guidelines, you know, like a book with a description of disease, it is already an algorithm that is syndromic. Still, we cannot implement the exact pathway that is proposed in IMCI if we want the tool to be meaningful, and especially to help clinicians to have a real proper assessment of the children. I see also that in the chat, we had a question on how do we improve the detection of severe cases. And I think that was part of our objective, is that the new structure of a CDSS will really push the health worker to do each of the steps that are for us key for safety. So we really try to make sure that or encourage them to go through a systematic check of the danger signs so that they can early detect the patient. And then if we go a bit further, I told you just earlier that one of our aim was to try to see how using this IMCI concept and approach with something syndromic, symptom-based, simple for the lay health worker we work with, that are non-doctors. We had to think widely with all group of pediatricians to think, okay, what is the best way to assess a patient, and what is the best sequence of things that we need to do, and adding some new condition to make sure that we detect the bacterial disease. There was also the need to restructure everything. For example, IMCI has a fever box that is a standalone box. For us, if we wanted to have a process that would help identify safely the patient that needs and the patient that do not need antibiotic, we needed to reshape all that and open completely this fever box, but integrate it in the entire structure of the algorithm. So what we have now is something that will first make sure that we detect the severe cases so that we can give a pre-referral treatment and refer. And then we go to a stepwise assessment, making sure that based on the symptomatic presentation of the child, we make sure that we look for and rule out all the potential bacterial diseases before we can reach some diagnosis that is an exclusion diagnosis that could be, okay, this child has no danger sign, no sign of bacterial disease. He can be safely sent home without an antibiotic, but with clear education of the mother of what are the danger signs that should make her or him bring the child back to the health facility. So this was for us highly needed to reshape completely the structure so that it's not anymore assessment of different syndromes that are, you know, side by side as it was in the IMCI, but something that is fully integrated so that we make sure that the child will receive the best care possible with regard to his presentation.
Thanks, Clotilde. And Rainer, can I also ask you the same question, but from the point of view of EPOC Plus that's mostly used for research and implemented in health facilities?
Sorry, maybe when I say it's for research, it's being implemented in a research context, but we're really trying to evaluate it in routine settings in the many countries we're developing it for. And so, you know, we share really a lot of things that Clotilde had said in terms of development of EPOC Plus and digitalizing the IMCI guidelines and national guidelines. And I think one of the most important things was trying to have a tool that follows the flow of normal medical consultation. And so when we were evaluating the different softwares for the execution of the algorithm on the CDSS app, we found that most software were actually developed for data collection with some limitations in following that clinical flow. So as such, under lead of Unisante, we developed our own software, allowing us to customize the app in order to better follow the normal flow, notably separating medical history from physical exam to tests and so on. One example that Clotilde shared is exactly another example of how we had to adapt the digitalization process and the paper guidelines in terms of emergency settings and emergency situations. So we kind of all acknowledge that a complex algorithm or CDSS may not be well suited to provide decision support for emergency situations. In fact, during feasibility tests, we observed a child being brought in with convulsions for which the healthcare worker immediately stopped using the app and provided care, but had difficulty remembering the correct treatment doses. And so based on this, you know, we developed an emergency button that can be selected anytime, no matter which patient they're dealing with, to get this immediate emergency management care so that a child with convulsions will get the exact diazepam dose and the process for managing that. Finally, in this whole kind of digitalization process, one of the big limitations to many of the softwares is that it often requires IT knowledge to program the algorithms and to interpret it, often not human readable as described in layer 2 by Nigel. So this makes validation and review of the algorithms difficult for national stakeholders and to be able to take ownership of the algorithms. So within our software, efforts were made to really create a platform that is easy to use for clinicians with minimal IT knowledge so that they can be human readable to program.
Thank you so much, Rainer. And you mentioned the term of validation. And so I want to maybe ask other members of the panel, and I think I can direct this question to Torsten. When you modify and translate an internationally acknowledged protocol such as IMCI, how do you ensure that the clinical content is clinically sound and that the final CDSS actually reflects the expected algorithm that you design? Torsten, I think you're on mute. Yep.
Yes, thank you, Karel, and good day, everyone. Well, I want to say that over the years we learned, and I think there are three aspects that are crucial in regards to quality assurance of CDSS. And the first is we're convinced that the final responsibility of the clinical content of these CDSS cannot be with the developers. It has to be the duty of the local health authority, which then has to approve clinical guidelines, also when they're deployed digitally. And therefore, in our projects, we let the clinical content of the newly transcribed algorithms be reviewed and approved by an expert panel, which then have an advisory role to the health authority on site, before we then finalize the development. And this routine in our project assures that the clinical algorithms in our CDSS meet both. So they're consistent with national protocols, but as well with evidence-based international treatment standards. The second thing, we as developers, we have to assure the technical quality of the tool. So for this, we introduce standardized validation test procedures into the development process. And we test the clinical reliability, basically asking, does the algorithm assess what it should be assessing? And also we test the functionality. So does the tool operate as it should? Does every question we place lead to an answer that is designed? And third, as we heard from Clotilde in her presentation earlier, the CDSS content and functions need to be tailored to the working reality on site. And in that regard, we felt it is very important that the algorithms are really continuously updated and revised. Otherwise, the CDSS will quickly get outdated and maybe perceived as bad quality. And from the implementation in Nigeria with Almanac, we learned that only with good quality tools we can gain the local acceptance, which is important, that the tools will actually be used and then continuously integrated also into routine practice. These are novel technologies, so there is a bit of a resistance maybe when we introduce them, but it's important if we want to improve and if we want to have impact. This can only happen if we introduce the tool and it's being accepted and used. There is no point, and they won't have impact if we introduce it and people decline to use it because it's too complex or bad quality.
Thank you so much, Torsten. Seems like there's a lot of efforts throughout the CDSS life cycle to ensure that the quality remains really high. And so it also draws the attention to the question of implementing these tools long-term while maintaining good quality. And so I want to direct this next question to Ricardo. With YEDA, you've now implemented the tool in several health facilities in Burkina Faso. When you plan to go to scale, like you've done in Burkina Faso, how do you plan this out? And what is the role of stakeholders ensuring the success of a scale-up process?
Thanks, Carol, and good day to everyone. The role of stakeholders is fundamental in the planning for scale-up. And what happened in Burkina Faso can provide important learning in that regards. As a reminder, in Burkina Faso, the Minister of Health, in collaboration with Terre des Hommes, had conceived the YEDA more than 10 years ago. And today, almost 90% of healthcare facilities in the country are equipped with that. And 90% of child consultations are supported by YEDA. To give the sense of this achievement, today, over 200,000 consultations are run every month in Burkina Faso with the support of the digital tool, for a total of today about 12 million. And the major lesson learned to achieve such a level of scale was actually to manage effectively all stakeholders. And the fact is that there are many more stakeholders than actually we think in the first place. On one side, the multi-sectoral nature of digital health already implies dealing with a wide range of functions and users, engineers and physicians. And our experience actually shows that there is a myriad of actors who have a stake or an interest, and they can either promote or block the scaling up of the project. even if the project is clinically and technically and medically the best digital health tool. So, and then another important aspect is that despite the size, digital health represents a novelty, triggering a diverse multitude of changes, direct and indirect changes, including resistance. So to reach scale, you need to gain the support of all of them. And this time and resource consuming. But let's start with the MOH, which is the main stakeholders. We all agree that the MOH should be in the driving seat to ensure a smooth integration within the health system. But the MOH itself is composed by a multitude of departments. You have the family and child health, you have the statistics department, you have health information systems, and then you have the program departments, malaria, etc., you name it. And not always with converging interests. So the question is, how do you navigate across them? And how do you ensure that they are simultaneously supportive and not blocking the new tool that aims to reach scale? And also the question is, at what level do you interact and engage with them? Do you interact at the political level or technical level, or both? Political, you have a stronger push, but it's more, of course, it's more volatile. And then there are also other ministries involved, which you need to gain their support too. The finance one, the telecommunications, in Burkina there is a Ministry of Civil Servants, and many others. And even when you have gained their support, this is not sufficient if you want really to go full scale. You need to get the buy-in at the operational level too, in the field level. One must deal then with the regional health managers, the head of the health districts, and make sure they're all truly supportive for the digital health initiative. What's in it for them? This is a question. It's probably because they can monitor better the initiative, for example. And then you have the healthcare workers, of course. You need to make sure that the tablet, the digital tool, provides a tangible value and help their busy, very busy life so that they can choose to use it because it's beneficial for them. Key stakeholders are also the communities, the child caregivers. What if it is one of the parents actually asking for the child to be consulted with the digital tool because they believe it provides improved care? What if it's the community actually that decides to raise their own funds to buy new tablets, to replace broken solar panels? This is what happens in Burkina Faso, thanks also to an important awareness campaigns being run beforehand. Again, having a scientifically bulletproof digital tool is necessary, fundamental, no doubt, but it's not enough. You need to fine-tune the tools, add additional features, modules, and articulate the process so that you create incentives for all. So I can go for hours to name other stakeholders. There are also international and local actors, research institutes, and so on and so on. But really, my message is I would like to underline the importance of managing stakeholders and incentives for them. I strongly encourage anyone working on the implementation of digital health tools to seriously think about the stakeholders and integrate the stakeholders analysis as a core area of intervention on top of the technical and medical one from the very beginning. Unfortunately, this takes a lot of time and a lot of resources, but it's essential. Thank you.
Thank you so much, Ricardo, for sharing those insights from your implementation of YEDA in Burkina Faso. I'm getting notices that we're running a little bit behind. So I just want to quickly ask, maybe Torsten, from your experience with LMIC, and Ricardo could also jump in to complement his response, but how do you sustain this initiative? It is an extremely complex ecosystem, and you've been in country for a very long time. So can you share a bit of your learnings from your implementations? Thank you.
Yes, sure. And I fully agree with what Ricardo just outlined. The stakeholders is essential to have them on board. And the good news is that I'm convinced that our CDSS approach is sort of sustainable by design. If we look, the global digitalization, it can bring great opportunities for LMICs, and it's happening fast globally, whether we like it or not, and will be a reality also in healthcare. But the good news is that we have solid evidence now that the CDSS are helpful in that process. We from Swiss TBH saw in a large effectiveness study we recently did with our partners in Nigeria on Almanac that the CDSS was indeed a key factor to strengthen a health system. It may have or it has a strong impact, particularly if the context is very poor in terms of resources. So clinical decision support systems appear to bring improvement. And regarding sustainability, the huge advantage of CDSS is that it operates quite well with the available resources that are really there and does not rely on ideal but unrealistic scenarios. Now, our job as the implementers is to work close with those various stakeholders that Ricardo just mentioned before and support the local health authority so that they can maintain the implemented CDSS independently in the long run. And I'm convinced that it is essential to make sure that we're not creating new dependencies from these countries, that these countries become newly dependent in other terms from high-income countries. For Almanac in Nigeria, we have therefore outlined an exit strategy for our engagement from the very beginning of the project. And this year in 2021, the project management will now fully be handed over from ICRC and Swiss TPH to the state primary healthcare agency. And I know Terre des Hommes and Ricardo's group, they're currently doing the same with Yeda and Burkina Faso. We're quite in close exchange, and we found the two biggest challenges that we, as well as Terre des Hommes, encountered during this handing over process are one, to support the required funding to cover running costs like server fees, costs for tablets that break, etc. And the second point is building up in-country capacity so that the local staff has sufficient technical expertise to manage and maintain these CDSSs. Therefore, in the past years in our project, we intensively trained our national partners on the required technical skills. And Nigel, you know, I'm very excited about WHO's plans to develop and publish the SMART guidelines. For this will give our colleagues in low and middle income countries a solid validated structure on which they then can base their future guideline updates on. So that is quite helpful in terms of sustainability. And maybe one last point on the management, on the independent management of CDSS in country. So even though we were in the lucky situation that we found very talented people in the country to work with, the remaining issue for their employers is to acquire necessary funding to keep these staff engaged in their positions over time. So besides handing over technical expertise, we are currently working together with them on business development plans that assure the required financial means that they can run the CDSS also in the future. Thanks. Over to Ricardo.
Thanks, Thorsten. I can only confirm what Thorsten said. Sustainability goes through the full integration of the digital tool in the health system. And this usually happens when the MOH runs it autonomously. And to ensure sustainability, as mentioned by my colleague, you need to build capacity, local capacity, to address the technical aspects of digital health. For example, it's not enough to say we host a local server or platform. You need a robust server that, in case it breaks down, it is quickly fixed and it doesn't take days and days. Otherwise, you jeopardize the whole digital initiative. And to achieve that, the required expertise must be in place. And unfortunately, capacity building does not happen from one day to another one. And you need a long-term plan for what, you need a long-term plan for that. And you need, this is be endorsed at the high level of decision makers. So it's important, and this is what we've done in Burkina Faso. We brought to decision makers two main evidence for that. The first one, like Swiss TPH, is to provide evidence that the digital tool actually achieves what actually has promised to do, so has an impact. And the second one is on the associated cost. So both reports are available. I know we are running out of time, so I will be very, very short, and I will focus mainly on the cost side, because this is quite important, especially when it comes to low-income countries. The London School of Hygiene and Tropical Medicine has run an independent large evaluation, including an analysis of the costs. And the result is that the clinical decision support tool, when deployed at scale in Burkina Faso, brings financial savings to the country, and that was estimated to 1.6 million per year, and that was conservative figures. So I think this, coupled with the evidence, there are strong arguments to keep the capacity building part of the digital initiative very high in the agenda. And of course, there are many more. This is a very, it's a question that actually deserves much more, but I know we are running out of time. So the floor is back to you, Carla, and thanks a lot.
Thank you so much, Ricardo. Yes, as mentioned, we're running out of time, but I do want to ask this last question before we move to our Q&A to Nigel, because with the SMART guidelines, I think a lot of organizations and individuals are very curious to understand the WHO's role in this field. There's a lot of new emerging players, people interested in developing new tools. What do you see WHO's role in this new ecosystem? And what is the place of SMART guidelines? What place do they hold in CDSS development and implementation?
So I think it's worth just, there's a couple of things about how we understand the word guideline and recommendations. That an instrument like IMCI is not a guideline, it's not a recommendation. That we have a process around assessing, for example, the efficacy of one antibiotic versus another, or the value of antiretrovirals for transmission or not. And those generate clinical recommendations. Those then get consolidated into a guideline, which is a document that simply says, this is the antibiotic to give on this circumstance, or what to do. That translation into an operational tool is really what IMCI has tried to deliver in years gone by. And that's what I would really say that that's what we're talking about today. So in one sense, the term SMART guideline, I think, is a little bit of a misnomer, because it suggests that the tool itself is a new guideline. For WHO, whether it's IMCI or any package, it is the distillation and it's the bringing together of multiple recommendations. And so there is a guideline process about, for example, how do you treat a child with severe malnutrition or whatever. And that is not the same thing as the SMART guideline per se. The SMART guideline is the translation of that decision about a clinical decision, and how do you put that into an effective way of health workers using that specific decision within a broader care context. And so I mean the beauty of the digital sort of solution to this is the rapidity or the potential to actually push out into the hands of health workers decisions that have been made around a particular intervention, and to get that converted into layer 2, layer 3. It doesn't matter whether it's a WHO app or whatever. It's making the layer 3 content available to whichever groups want to incorporate it in, because these are all open source. So I think Torsten said this is the direction of travel. There's no doubt about that. And WHO's commitment to taking what we would call clinical guidelines and putting them into layer 3 content at minimum that anybody can then use and push out. That's the primary commitment. We also want to develop a WHO reference tool, reference app that others can use. And it's for all the reasons that Ricardo, Clotilde, Torsten, Rainer have been saying. But that's unquestionably the direction of travel. The one thing there was a couple of things just earlier I just want to, and I'm also conscious of time, is that one of the tensions in all of this, and it's a tension that Rainer, I think, alluded to, of field testing in a research environment, but trying to make it as real world as possible, is the tension between quality and time. That the quality of care, we have known for decades that people take shortcuts with care because they feel under pressure with time. And I think if anything, the digital solutions can increase the amount of time that health workers go through, but they then follow the pathways with greater fidelity. But it has an impact on time. And that is a cost that is very hard to measure. By the same token, what's added is the quality of care and being able to measure that quality of care. And that also allows things like, data going back to district health systems, which is a major time saving where you can have almost real-time delivery of data back to. So it's a very complicated equation of how do you balance all these things. And I think the opportunity that the digital solutions provide is obviously enormous. But I think it's true that quality takes time. And sorry, the one last thing is that Rainer, I think, commented earlier, IMCI as a paper-based tool, there were many loose ends because if something wasn't addressed on paper, then the health worker was left kind of undone. In the digital process, you can't do that because people end up in sort of a cul-de-sac where they don't know where to move. And so the digital process actually forces a set of decisions. What happens if referral is not possible, or if referral is going to be delayed? What do you do in that circumstance? And that pushes things beyond where IMCI is at the moment. Thanks.
Thank you, Nigel. Before we move on to the Q&A, just as a follow-up question, you mentioned the concept of time. Is there a vision at WHO of integrating, moving towards a more integrated approach to healthcare? Since the guidelines or the SMART guidelines are taking narrative form and providing guidance to digitalize, is there, in that vision, is there also integration of different, I guess, disease program or clinical care guidelines that are disease-based?
So I think that's, the quick answer is yes. And that's one of the ideas that, although we talk about M-Care being for emergencies, there are stable settings where children can be, a displaced population can be in a particular setting for 4, 5, 6 years. And so their health needs are not restricted to disease. They need immunizations, they need guidance on, breastfeeding, on early childhood development. So the vision is definitely both in M-Care, and the probability is that WHO I think it's already sort of in the corridors committed to a digital app for the non-emergency setting. We have been talking for the past couple of years about well child visits, which is about preventing disease and promoting health. And so those are definitely in the pipeline. And again, one of the reasons for taking on a platform ourselves rather than simply adapting what has already been, for example, AIDA, because we see the need to broaden beyond disease, that we want a platform that can fully offer health promotion, that allows us to bring many of those elements in, to bring chronic care around disability, to be able to provide, we already have DACs for adolescent mental health. So the answer is unquestionably yes, Carol, that we want to see within M-Care, there will be a division of, is the child sick? Is a child coming because they're well? And that it is routine care. And so that's already factored into M-Care. It is not, it will be IMCI and it will be more.
Thank you so much, Nigel. So in the last few minutes, I'll take a couple of questions from the Q&A session. The first one is to CDSS representatives. Do you feel your work and the lessons learned in trying to operationalize the guidelines into CDSS will now filter back into the narrative guidelines for them to be updated? Would anyone like to take this question on? Clotilde, would you like to take this question?
Yes, I mean, very quickly, I think this is really already happening. We will look at the MSF guidelines. What we've been developing with MSF eCare was actually the first protocol for treatment at primary care level for MSF. And during all this process, we really realized, I mean, this is what we were talking about, the iterative process. And I think it's also linked to what Nigel just mentioned, like IMCI was already trying to integrate different kind of guidelines and recommendation. And it pushed us to go further in trying to give recommendations that are adapted to the different presentation of the children. So every time we iterate, we were building a new tool, we were confronting it in the real clinical practice, and we were realizing that some of the elements were missing, and that helped us improve the protocol that we had built. So it's not yet narrative guidelines and the WHO one, but I think that's also all the objective and the long-term objective of our dream we have, is that by doing that, we also try to drive a better clinical practice, but all this practice generate data. And that was another question in the list of questions, that was also what room for AI or for machine learning. And there is some of the members here that have already engaged in that and looking at how all the data generated by this kind of tool could be, by the support of machine learning and AI, help us to identify how we could improve the management, reach better outcome for the children. That's also, I think, the layer 4 or 5 of the SMART guidelines. For us in MSF, we are not yet looking at that, because we are much more looking at in humanitarian context, we are much more looking at tools that could improve the health worker performance, the capacity building of the health worker. We will not build tool that we wanted the health worker, that this is the future probably of this.
Carol, could I add there quickly, just again, this comes back to the definition of, feeding back into a guideline process. The question is whether I think there's scope for both, that if through AI or any, effectiveness evaluation, you see and you can learn better about the sensitivity of predictive indices for saying which child need antibiotics, which one don't need it. That's one type of guideline. That's one type of clinical decision where the evidence from digital tools may be part of a general consideration of the evidence for that type of decision. That is different from the way or it could be different from the way in which care is delivered. And so the sequencing, there are two different things. One is the evidence about, what child needs which antibiotic. And then there's also the sequencing of care. And clearly the type of data coming back from digital platforms can contribute to both. But the two are probably slightly different. One person just asked about, the WHO materials for emergencies. And we went through the same sort of consultative process. but we see the solution and the way in which guidance for emergencies as being a really important area where we haven't had evidence coming from emergency settings. It's often a very complex field in terms of doing trials, for example. It's complex from an ethical perspective of including within research, but there are actually many many emergency settings where research could be done. And certainly, the prospect of using digital tools within that would be very attractive. Over.
Thank you so much, Nigel. I think we ran out of time. There are a lot of very good questions in the Q&A. I think what we can actually, there will be potentially more discussions around this topic in future conferences. But please do reach out to the panelists. I think their information should have been shared potentially in the invitation. But I think I will now hand over to the GDHN organizers to help us close this event. Thank you. And thank you to all the panelists and the participants today.
Great, thank you, Karel. Yes, thank you all. If you are still here with us, I know we have run over time, but there was a lot of interest and questions and a lot of really great discussion. So I just want to thank all of our panelists and our moderators, so Karel, Torsten, Rainier, Nigel, Clotilde, and Ricardo, for being here today and sharing your experiences in this process. I look forward to hearing more about this work and how it continues to grow. I think it's a really timely topic, as we're definitely moving from pilots to real implementation and looking at how digital can really impact health outcomes. And an important piece of that is looking at how digital tools are improving quality of care and service delivery. So I want to thank you all again. Thank you to Frederic and Vanella and others who were here in the background preparing for this session. And again, thank you to our attendees for being here today. And I hope you all have a great rest of your day wherever you are in the world. Thank you.